Well, hello and welcome to another Sunday morning coffee with Dr. Childress. Today, I've got my owl mug. Um, it's kind of a little joy every morning of selecting what sort of coffee mug from my among my selection. Today, I'm going to be relaxing in my coffee talk. I also have a cat underneath my feet here. He was a little annoyed I'm talking to you. Um, I don't need to be as productive all the time as I have been, and so I'm relaxing this Sunday morning. Just going to talk uh, about general things, particularly in this. I want to vent a little bit or disclose a little bit about the current state of the forensic custody evaluators. Because that's what I'm doing. I'm looking at forensic custody line by line for a review of the custody evaluations. I think they are a failed experiment in service delivery and need to go away. The forensic psychologists, however, will be of a different mind on that. They want to remain in the family courts doing what they've always been doing, which is these failed forensic custody evaluations. So that's the current state of kind of my world, is doing second opinion reviews on them and challenging them. And what I do generally is I take a look at the situation. So back in 2008, 2010, I looked at the family courts, figured out what the problem was. The problem was the forensic custody evaluations and the low quality of forensic or low quality mental health services that are in the family courts. The solution is to elevate the standards. And what's the problem? The ethical standards. There's violations to 2.01, boundaries of competence, 2.04, the application of knowledge. They were making stuff up like parental alienation and stuff and are fighting and arguing about that. No one's applying actual knowledge. And so I figure out what the problem is and I figure out what the solution is going to be, which is the application of knowledge and the improved quality of mental health services. And as I began to look at that, one of the first places I went to, once I kind of got oriented, figured things out, was I turned to what the forensic psychologists think they're doing. And I turned to Stahl and Simon 2013. They'd written a handbook on forensic custody evaluations, published by the American Bar Association. So they got a handbook on it. I read their handbook, or at least enough to realize what they're thinking. And they made it very clear in chapter 2, Stahl and Simon did, that they are doing something different than clinical psychology. Well, that's a problem. And they created a straw man about what clinical psychology is subjective and forensic psychology is objective. No, they're not. First off, clinical psychology is not subjective. We apply knowledge like the DSM-5 and as diagnostic criteria. So, no, that's not true. And then the second part, that they are somehow objective. No, that's not true either. And there's tremendous bias in the procedures of a forensic custody evaluation. And what they did is they developed this new role for psychologists, this quasi-experimental role. And they say, our role is not to be helpful to the parents or children, which I find astounding. So they're not there to help the children. They defined their role as assisting the court in its decision making regarding child custody. Well, that's not a role for doctors. We don't decide on child custody. And I'm pretty confident the court can decide on custody without our help. And the issue that's the court's facing is there's attachment pathology. Child's rejecting a parent, and there's conflict, and the parents are saying, oh, that parent's bad, and the child doesn't want to be with them. That's all pathology. What the court would benefit from is a diagnosis of what's going on. Is there child abuse? Yes. If a child's trying to flee a parent, there's child abuse range parenting. And so which parent? Which parent is causing all the child pathology? And what do we do about it? What's the treatment plan? So we need a diagnosis to identify the cause of the problem, and then we need a treatment plan to fix it. And that's what the doctors should be developing and providing that information to the court. Instead, that's clinical psychology. Instead, the forensic psychologists made it very clear they are leaving clinical psychologists. They don't agree with that approach, so they're going to leave and then create their own quasi-judicial role with an entirely new approach to assessment. Okay, so the rest in clinical psychology, when we're doing assessment on something, there's a question that comes in, and we apply testing to the question. If we don't need to have testing to the question, then we apply the diagnostic criteria to the question. But we have a question coming in. The question out of the forensic family courts is, what should the child's custody be? That's the court's decision. Is there child abuse is something we can answer, and we could apply. But there's no testing that would apply to the family court question, and we would go through clinical diagnostic interviews. Instead, what they did was come up with an entirely new approach to be objective. It was awful. They tape record everybody's reporting. So it's basically fact finding for the court. That's not what clinical psychologists do. The court fact finds for itself. And so they're basically fact finding, which has, in the legal perspective, if you listen to the New York Blue Ribbon Commission, the commissioners talk, that's an entirely inappropriate role for psychologists to be fact finding for the court. And it introduces so much procedural stuff because the doctor is not maintaining everybody's rights in the gathering of that information or the reporting to the court. And so it's just really messing with the two systems. They're coming into the legal system and messing with it in this new quasi-judicial role. But they did that. And then they record everybody, which is not a clinical diagnostic interview. In clinical diagnostic interview, when you say, I'm sad, I've got major depression, bipolar disorder, suicidality, just a variety of things, your symptoms, has there been disrupted eating, disrupted sleeping, any guilt, how often, how high, how all these things pop up. The moment you say, I'm feeling a little sad, all these differential diagnoses. The forensic custody evaluation doesn't do that. That's not a clinical interview. They just simply let people talk, record it, and then present the transcript of the recording, basically. That's the bulk of what they do. Then the next section is they do a home observation. Why? Because they threw a whole bunch of hodgepodge stuff in. They say sometimes clinical psychologists use a home observation. Sometimes they talk to person. Sometimes they do testing. So we'll just toss all this stuff into a pot with no idea and question. It's not answering it. It's an entirely bad approach to assessment that they're just making up out of whole cloth. They're not applying any standards of psychometric procedures. So it violates 1,000 psychometric procedures of assessment. They're just tossing everything in. And they're ignorant. They lack knowledge or information. They don't know family systems or delusional thought disorders or attachment pathology, nothing. And so they make up stuff to hide their ignorance because they're just ignorant like a rock. And so they make up, for a long time, it was this parental alienation. And so they fought and fought and fought. Is this the new pathology? No, it's a shared persecutory delusion and factitious disorder. Would you please apply the DSM-5? No. Do they know about delusion? No. Do they know about attachment pathology? No. And so they're just ignorant. And so they've developed this quasi-experimental role. and there's forensic custody. And it completely failed. Absolute failure. So now we need to go back to clinical diagnostic assessments. We need to get grounded back again in healthcare. They took everybody off on the wrong track, just like Gardner and PAS took everybody off on the wrong track. They took us a wrong way. So now we need to get grounded again. However, that requires admitting this is a failed model. This is a failed new quasi-experimental role. There's no role for that for doctors. And so they're not going to want to do that because that means that they have to leave the court because that's the only thing they do. They don't know attachment. They don't know family system. They don't know how to diagnose or treat the pathology. They just make stuff up, okay, because they're entitled to, or at least they believe they're entitled to make stuff up. Sense of entitlement, sense of grandiosity. They kind of think they have special knowledge that no other psychologists, clinical psychologists, don't know stuff. We're special psychologists. So grandiosity, a sense of entitlement, absence of empathy. Okay, I'll get the quotes out where they say, we're not here to fix things for people, and we're not here to be empathic to them. We have a new role with the court. So absence of empathy. Shall we check? Haughty and arrogant attitude. Shall we go for 4 on that? How about splitting with the clinical psychologists? They're all good and the clinical psychologists are all bad in the family courts. The clinical mindset, they call it, is not appropriate for the family courts. Well, I would say the forensic mindset is not appropriate to the family court. So what I did, back 2010, 2012, is figured all this out, see where the field is heading. We're going to be returning to established knowledge. We're going to be returning to clinical diagnostic interviews. Then everything I did back then was on that path to now. And so I've just been documenting things and documenting because I know they're not going to move because there's conflict of interest and they're kind of ignorant and unethical and they have all sorts of problems. And I know that in 2010, 2012, because I look at the problem. And so I know we're going to be shifting away. So I've kind of been moving to that and I've documented, I've told them what it is, in foundations here. Okay. I described it to them. Okay. In detail, across 3 levels of analysis, so family systems, personality disorder, and attachment. Across all 3 levels, I described it in detail, plus across between the 3 levels. So the attachment pathology produces the personality disorder pathology that produces the family systems pathology. So I describe it this way and I describe it that way. Okay, so basically I'm spoon feeding them the nature of the pathology. Here it is. I describe it to you, 2015. And I tell them exactly what the DSM diagnosis is with code numbers and everything on it. Okay, so there it is. I've spoon fed them the diagnosis and then I tell them how to assess for it. Okay. A little simple. I'm spoon feeding the little toddler forensic psychologist on how to assess for the pathology. Then I also tell them how to fix it. Spoon feeding them how to fix the pathology. And I shouldn't have to do that to doctors. They should be acquiring the knowledge. I should not have to educate the doctors. And so I'm teaching the parents to educate their doctors about what the pathology is because the doctors are so bad, these forensic. And so I know where we're headed. And that's why I say I work 2 to 5 years ahead. I'm lining myself up to where we're going to be, not where we are now. Meanwhile, I'm watching the forensic psychologists respond to the new knowledge that they are being confronted with, and they're not, because of their conflict of interest. They want to remain in the family courts, and they don't want to admit that what they're doing was a failure, because that's colluding with the child abuse and all sorts of malpractice things. Well, I've reached the point now, this weekend, last week or so, where now I'm returning back to their original articles, 25, 27 period. I can go back to 1990s even. They're referencing back to the 90s on some of this stuff. And so I'm taking a deeper look beyond Simon and Stahl, and then, or Stahl and Simon was 2013, second edition, same book, 2020. So they got Simon and Stahl, Stahl and Simon. I'm moving beneath that into the journal articles back from the 2005. Now, if you're a forensic custody evaluator and Dr. Childress is going back to your 25, 27 area articles, and maybe even back to your 1990 articles, I'd be worried about that, okay? Because the line I'm tracking on that is they knew all this stuff ahead of time. They knew all this stuff back then. And that's what I'm pulling out. They're saying these evaluations, the role, this quasi-experimental or quasi-judicial role is wrong. It's unethical. There's problems with it. They were being told that in some of these articles, and they are acknowledging that in their articles. And there's tremendous bias to these custody evaluations. And that's acknowledged. And that's known 20 years ago that they are just invalid, essentially, for the bias. And here's what they're saying, okay, on the bias. They're saying, yes, there's all these different sources of bias associated with this forensic custody evaluation. And the solution is two-step solution they offer. One is for the custody evaluators to be aware of their bias, and two, for the custody evaluators not to be biased. That's their solution. Okay, first off, most, if not all, of the bias is unconscious, and they don't think they're being biased. They think they're being objective. So there's no way they can be aware of their bias. That's stupid. That's a thought disorder, basically. You can't be aware of unconscious bias. And I got them in other places saying it's unconscious bias. And so you can't be aware of it. So step one is impossible. And step two, stop being biased. It's the honor system. You have the forensic custody evaluators on the honor system to be objective. And that's your objectivity, is the honor system. They're awful, awful, awful. And that's the foundations of stuff. And then I've got critiques. I'm going back into the, they're saying this stuff is bad, is really bad. And now we're here 20 years later. And yep, it's really, really bad. And we need to go back to clinical diagnostic assessments. We need to go back to the foundations of healthcare that they left. So they left the foundations of healthcare with this quasi-judicial role, and the Richard Gardner, left the field of diagnosis with his new syndrome proposal that's not in the DSM. He should have stayed in the DSM. It's a factitious disorder. Okay. And so he even had a shared persecutory delusion, shared psychotic disorder in DSM-4. So if you'd stayed in the DSM-5, you'd have diagnosed it and we wouldn't have had 20 years of controversy. But instead, Gardner did a very bad thing. He left the field of standard healthcare, and everybody told him, don't do that. No new pathology. But he insisted. And then he got a little cadre of people who insisted on making up new pathology rather than remain grounded in established knowledge. Family systems, attachment, personality disorder, DSM-5. Stay grounded. Nobody did that. The Gardner people let him off. And the forensic people did the same thing. They led everybody out of healthcare into this new quasi-judicial role. Well, now, 2014, we're at the position where we're going to have to switch back to diagnostic assessments. I mean, this is child abuse in the family courts. It's a factitious disorder. It's a shared delusion. It's child abuse and spousal abuse, using the kid as a weapon. We need to get back to diagnostic assessments and the application of knowledge, family systems, personality disorders, delusional thought disorders, just attachment. So the attachment pathology, let's apply attachment. Just on attachment, just on that. I'm early childhood mental health. That is spot on attachment. I have certification in infant mental health. That is spot on attachment. 0 to 5, that's your attachment period. I know 2 different treatment approaches to attachment pathology in early childhood. 1, watch, wait, and wonder for infants. 2, circle of security for preschool age. And I know 2 different diagnostic systems in early childhood, the DMIC, which is stronger for autism spectrum, and the DC 0 to 3, which is stronger for attachment. So not only do I know the DSM, I know 2 different diagnostic systems relative to attachment zone. And I know attachment. So let me tell you something. You don't have any experts in attachment pathology outside of early childhood because attachment pathology does not arise outside of early childhood. If you see an attachment pathology in an 8-year-old, you will see it in the 3-year-old. If they can get past age 5 without significant attachment pathology, then they don't develop it later on. So it's not in the world. That's why you don't see any attachment treatments for anybody in the actual real world. And because you don't see this pathology in the real world. You only see attachment pathology in early childhood, 0 to 5. Except here in the family courts, you get an attachment pathology that emerges in an 8-year-old around a divorce or a 15-year-old around a divorce. It's around the divorce. It's a false attachment pathology. It's a factitious disorder imposed on another for secondary gain to the child. Or it's child abuse by the targeted parent. If you see something pop up at age 12 where the child's seeking to flee that parent, that's child abuse. So let's get the diagnosis for child abuse then. Okay. Or it's a factitious attachment pathology, one way or the other. If you know attachment pathology, but they're ignorant like a rock. So anyway, we're at a phase now where we need to get back to clinical diagnostic assessments, the application of knowledge, ethical practice 2.04, 2.01. We just improve the quality of healthcare out here. A doctor should not have to guess what your diagnosis is. If I'm doing a second opinion, you should explain your diagnosis and give the reason for it. And I'm going to be looking shared delusion, child abuse, spousal abuse, factitious disorder. Tell me yes, no, whatever it is, I shouldn't have to guess. In addition, your patients should not have to explain the pathology to you. Okay? No. Patients should never have to explain the pathology to the doctor. That's just foundational healthcare. Okay. So we're going to improve the standards, but then all the forensic custody evaluators, we're going to acknowledge that it was a wrong role. There's no quasi-judicial role for the family courts, and we're going to return to healthcare. You were wrong. Your experiment failed, which means they all need to go away. All your top-tier forensic custody evaluators with the big vetoes and years of presenting at a conference need to leave the family courts. Okay. And they're not going to want to leave. So that's the current situation. We have a cover-up by the top-tier forensic psychologists regarding their failed approach. And that's going to continue to get worse and worse. They're going to continue to try to cover up that it failed, and it's going to be increasingly emerging and it's a failed approach. And we need a clinical diagnostic. And then not only the cover-up, they will be intentionally disabling the mental health response. So we need clinical diagnostic assessments, but they're going to be preventing families in the court from getting those, because the moment they do, they have to go away. And so all of that creates a tremendous conflict of interest within the top tier forensic psychologists who are in leadership positions within the APA, the AFCC. All those top tier are now in a tremendous conflict of interest, where they are actively disabling the mental health system response of diagnosis and treatment for their own financial and career status gain. But if they don't do that, then they need to admit that their approach is a failure, and they need to go away, and they need to kind of acknowledge that they destroyed thousands of lives as a result of their poor judgment in creating its new quasi-experimental role for themselves, and leaving healthcare. So I'll go back to Stahl and Simon and Stahl of describing their reason for existence and the clinical mindset versus a forensic mindset. And I will challenge that and say, no, that's what they did was a straw man. That's a lie. And they're not objective, and clinical psychology is not subjective. And we need to go back to that. And so let's have an open debate on that. The role of forensic and clinical psychology in the family courts. I'll represent for clinical psychology. Get one of your top tier forensic psychologists to represent for themselves. Let's put it online. AFCC, let's host a debate. APA, let's host a debate. The role of forensic and clinical psychology in the family courts. Dr. Childress will represent for clinical psychology. Find your forensic psychologist. And then let's expose the cover-up. Let's expose how they're disabling the mental health system for their own financial gain. And let's expose the conflict of interest that's currently present. And now you will not see that debate happen because the forensic psychologists don't want that debate to happen. They want to just keep doing everything they're doing. And no, we need to change. We need to fix things. So with that, I'm going to head off onto my Sunday, and I'll get back to maybe some more topical issues in the family courts coming up. But it's going to be a difficult position for the forensic psychologists right now. I don't know what they're going to do. Either you acknowledge that there's no quasi-experimental role, or that's a bad role, or at least discuss it, at least start offering the courts and families clinical diagnostic assessments, even if you disagree with them, at least provide them into the family courts. Holy cow. And then learn what you're doing. You need to know family systems. You need to know attachment. What do you think you're doing if you come in here and you're violating 2.01? You're not even competent to be here. And you don't care. You're lazy. We need to get a handle on the professional standards of practice, at least to the level of the APA Ethics Code, 2.01 and 2.04, at least to the APA Ethics Code level, please. Can we start there? Which raises the question, where are the licensing boards in all of this? They've allowed this massively inferior quality of services for 40 years, provided to parents that have misdiagnosed the pathology, destroyed them. They're not competent, violation 2.04 to 2.01. And the licensing boards are just like on the sidelines entirely regarding this. Why? I bet you if you look, you're going to find the forensic psychologists are on the licensing boards. Mm-hmm. They're disabling the licensing board response to the incompetence. Wow. Cover up, conflict of interest. My goodness. That's why the New York Blue Ribbon Commission said they need to be eliminated, and no amount of training is going to fix it. To fix the bias, fix a conflict of interest, fix the problem. We need to stop the experiment and go back to standard healthcare. Doctors need to be doctors, diagnose and treat pathology. Judges can decide on custody. So with that, good luck, everybody. And I'm going to go off and start my